So this is a session on the healthcare home. I see that you've needed no encouragement to get going on the questions. They're already flooding in on the healthcare home. You've heard a lot about it. It's an important issue. 200 practices are going to be trial sites for successful implementation further on. So this is not a pilot, it's a proof of concept. We've got more pilots in Australia than Qantas. We need to actually do proof of concepts. We've got a panel to discuss this with you, but it is a whole of room conversation. Join in. If you are frustrated with the polling, just put up your hand and we'll take your questions and comments in real time rather than waiting until the end, because the end will come sooner than you think. Let me introduce our panel to you. Janet Quigley is here, who actually has responsibility for healthcare homes at the Commonwealth level at the moment, and Janet is Acting First Assistant Secretary of Health Systems and Policy in the Department of Health. Do you want to come up, Janet? Sit anywhere you like. Leanne Wells, who's CEO of Consumer Health Forum, but has a strong background in general practice, having been CEO of AGPN after Kate, I think, wasn't it? And then Medicare Locals, the National Medicare Local Organisation. Tracy Johnson, who's CEO of Inala Primary Care in Brisbane. Karen Booth, who is your president. Heather McDonald, who is Director of Education and Clinical Use at the Australian Digital Health Agency, which is what has supplanted NITA. And last but not least is Bastian Seidel, who's a Tasmanian general practitioner, but he's really here because he's president of the Royal Australian College of General Practitioners. So I'm assuming that you've got some basic knowledge about healthcare homes, but here's time also just to check in about what is going on. And I might, so Janet, just tell me what you're out and about, you're talking to people. So first of all, when are the trial sites going to be announced?
So we hope that will be done in the next week. So we've
after
finished
the budget.
After the budget. So we've finished the assessment, and we're in negotiations now with the Minister's Office just on the timing of that. And because the budget is imminent, we've just got to work around those timings. But we expect it to be in the next week.
So you've got a core set of principles. How much diversity is there in the applications in terms of how they would apply the healthcare home? Because you're up for different models, aren't you?
Yes, we are. So because this is an opportunity to validate and test all of the elements of the healthcare home model, the intention was that we had as much breadth as we could in the practices that would be participating in the first stage. So we've applied a sampling frame over the top of the application process, and it makes sure that we've got a good spread geographically. We're looking at different business models, which is large, small, corporates, etc. Also looking at different levels of capacity, because we can't just assess this based on practices who are already working well in this space. We also need to understand its impact on those that aren't quite at that sort of forefront.
And it's across 10 PHNs, so it's about 20 practices per PHN that you're going to select?
Approximately, yes.
Right, so it's not diluted across all PHNs?
No, we've focused on 10 PHN regions. We've used their footprint to guide the geographical spread, and that's ensured that we've got the remote, the rural, as well as the metro.
So what are the commonest myths and misconceptions you hear about the healthcare home at this point?
I think a lot of people are focused on the funding model and think that that's the key element. And while that's critically important, what we need to see is different business models that are applied in the healthcare home. Otherwise, if you take the money and don't change your behaviours or your practice, then this won't, I don't think, achieve what we're trying to. So it's driving different business models, which is supported by a different funding mechanism.
So are you paying for outcomes, as Kate was talking about? In other words, what are the outcomes you believe you're paying for, and how will you know if you've got them?
So we are driving, I think, or looking for an efficient model of care which uses innovation and flexibility. So looking at different things, because we've moved away from the transaction-based MBS model, we can drive better use of telehealth. We can use different mechanisms for engagement and communication. So that's one thing that we'll be looking at through the evaluation.
That's a process thing rather than an outcome.
It is a process. We're looking at, one of our key objectives is to reduce avoidable hospitalisations, where that care can be better met in primary care, as opposed to people landing in hospital where it's been because they haven't had appropriate access or support in the community. So that's one of our key achievables or key outcomes, is that we can reduce avoidable hospitalisations where that care can be better managed in primary care.
So you monitor that data point?
Yes.
Tracy, you were nodding vigorously there, so you're a signed up believer?
I am. Card-carrying member of the healthcare home team.
And is that because of your experience at Inala or just generically?
Certainly at Inala, we've been doing as much as we can under the current Medicare funding system to make sure that the care we deliver is the right care, right time, right place. So we've got a large multidisciplinary team. But I've also spent a lot of time overseas, and this is not something that Australia's plucked from nowhere and gone, gee, imagine what this would look like. This is something that's been working in nearly 30 countries, in many cases for a long time.
So, but just correct me if I'm wrong. I mean, so the Americans kind of jumped on it, who've got a very primitive primary health network care system compared to us.
Yes.
But haven't we always had healthcare homes? Isn't that what Australian general practice is?
And I think that's actually the strength of what we're trying to do. There's a lot of people in primary care who are passionately attached to their community, equally attached to their patients and the people that they work with. So this is our opportunity, rather than saying in 1984 the world was solidified around a Medicare schedule. This is our opportunity to say, okay, who are our patients and what are all the things that we actually need to do for them, rather than the sorts of things that the Medicare schedule keeps telling us we can do for them. So we can embrace who we already are in a more flexible way.
But who you are already, Bastian, is how many avoidable hospitalisations are there in Australia? What, 600,000 a year? Probably more than that, actually.
Absolutely.
And at least 50% of them are amenable to better general practice. Therefore, one would assume that there's a big problem with Australian general practice. You're not doing your job well enough.
Well, thanks. That's a nice introduction. I think we are. And let's actually go back what healthcare homes actually is, the way the governors proposed it. It's actually a capitation model for funding, not more, not less. It has nothing to do with the clinical model. So what it is, it's a solution to a problem that doesn't exist in the first place, because costs in general practice have been actually steady over the last 10 years. So on average, the federal government spends $30 per person per month on general practice
the
only.
MBS item, general practice has responded to the MBS freeze by increasing the number of items, and therefore GP salaries have remained the same, if not increased.
So again, if you look at the evidence and look at the funding, you actually see that the MBS spend is very static over the last 10 years. Never mind how often patients are seeing their GP or not. It seems to be balancing itself out. That's what the data actually proposes. Unlike public hospitals where you see a funding increase and spending increase of 19%.
But your own college has supported capitation for years and bundled payments and how you should get away from fee-for-service.
So there's a difference between a blank capitation, as healthcare homes has proposed, to shifting the funds to where the evidence is. We are supporting the idea that funds should be redirected from the tertiary care sector to the primary care sector. There's no doubt. We believe we can prevent 6% of all hospitalizations. That's going to cost the taxpayer $2.5 billion. We believe we can prevent emergency department consultations. That would cost, $1.6 billion every year. That can go to general practice. And of course, we can reduce outpatient hospital consultations, not $150 million. So there are $4 billion we can actually save in the hospital system. If we take $2 billion of that, put it into general practice, then we can do really good work there. So that's when we are talking. But by capping the funding for general practice and say, well, you are getting a fixed amount and you're doing all the after-hours care and you do some quality outcomes framework and you're doing all the nice things, telehealth and emails and anything, it's just not realistic. It's just not going to work. So my concern is the trial is set up to fail, and that's indeed a wasted opportunity.
We'll come back to that later. Leanne, what's the view of consumers?
Look, I think we are quite excited because it is quite a fundamental shift in policy. We've been operating under a...
So you don't agree with Bastian?
Look, I think we've got to start with something. That's the message from the consumer community and the community. And I would bring the discussion back to the survey that the government did. The Primary Healthcare Advisory Group got over 1,000 respondents to a survey that the Primary Healthcare Advisory Group did that I was on and others were on. at the outset of this process, which really echoed what we here at Consumers Health Forum, is that the experience of the system, the experience of care, and this is about the system, not just about the experience of general practice, is that we're managing more multi-morbidity, more complexity these days. We need the system to better connect up. So what better way to do that? And as Bastian's saying, all the evidence is that if you've got, you know, across the world, high-performing health systems have strong primary healthcare backbones. What's the backbone to our primary healthcare system? It's the general practice setting. What we need to do is bolster that setting by paying more for value, less for volume, better quality, patient-reported experience outcomes, patient-reported outcome measures. You know, give practices the flexibility and the autonomy supported by a flexible funding model that they can put together wraparound services for patients. That's you know, I mean, I think if we've got a policy willingness to start moving in that direction, you know, we don't need to have big bang change. It's about starting somewhere.
What's your point about, I mean, Bastian has, I mean, I'm not sure I agree with everything that Bastian said, but there is one issue here, is that on a fee-for-service system, it comes to the GP, you know, a percentage goes to the practice costs, depending on the model and the general practice. So that's the GP's income. If you're going to take away some of the MBS, bundle it up and give it to the practice and not the GP, you could actually see a diminution in GP income. Therefore, what is the incentive for GPs to get involved?
You asking me?
I am.
Oh, look, I mean, I don't want to get into a debate about the funding. I do think, and CHF has taken this position, that the funding is probably underdone. But until we actually get in and test that, we don't know, do we?
Heather, one of the questions here that's getting a lot of votes is that the healthcare home will need a lot of data accurate data for evaluation. You know, how is the data, how are the data going to work? And what's the role of My Health Record in all this?
Well, My Health Record will be the underpinning infrastructure that will support the linking between the systems and the people. So the connectivity needs some digital infrastructure to allow the hospitals to be viewing shared health summaries that have been uploaded by the GPs, sharing with allied health. So there's that's going to be happening. I'm just thinking about the data. At the moment, there's no secondary use happening at all with My Health Record. But the evaluation will be including a lot of information that will be collected. So it's not necessarily going to come from My Health Record.
So will you have additional functionality on My Health Record for the healthcare home?
Look, the care planning systems are all going to be starting to upload shared health summaries, which will enable more people to be having access. There is work being done about looking at a standardised care plan, so what sort of data elements would be in that. That's work to be happening in the next year on the work plan. So those elements will inform some of the evaluation that we'll be working with the healthcare homes people to ensure that they're the right data points.
And what's going to happen with practice nurses in relation to all this?
Practice nurses can already upload shared health summaries.
Can I just take a poll? How many of you are doing that? So about 40% of the room, maybe?
Yeah, so most of them are working with their general practices to have a collaborative approach to uploading. When they're doing the care planning process, they're often uploading a shared health summary as part of that process.
Well, clearly not as reflected by this room.
They will be next week.
Right. Karen, what's the opportunity for practice nurses?
I think one of the opportunities will be that they will actually get to showcase their skill set. And there are a lot of nurses who are already doing amazing things, but it's not reflected in a lot of evaluation. There's not a lot of research going on to, there's some research, but not a lot into the actual effects of nursing care and that it has on patient coordination, patient outcomes, patient satisfaction as well. I think that a lot of us here will be working in very high-performing practices who already have a very good multidisciplinary team model. They have a GP that works closely with the nurse that will help to manage the patients, map out their care, look at the pathways that's needed to help that person stay at home, improve quality of life, halt, or you
So
know.
you think this is already happening now?
This is already happening, but it's not very well recognised.
So could you pick up your hand if that describes the environment that you're working in? So about 15% of the room. So it's not happening that much.
No, and I think it's very easy to look at high-performing practices that a lot of us work in and think this is the model, but it's actually not. And we need to have some sort of systematic approach to properly managing care and giving patients access to to help to stop those avoidable hospitalisations. And perhaps this formal process that will come through the healthcare homes will actually help those lesser achieving practices build up systems that they can then use to achieve that better outcome.
So Tracy, what does working to this full scope of practice actually start to look like as a manager of a primary healthcare organisation?
I think that over time it means we're going to have bigger teams.
Just bring the microphone a little bit closer to you.
Bigger teams, because we're going to be enabled to have more touches to the patient. We're going to be enabled to be in the digital world that we live in for the rest of our lives and not necessarily have to see patients physically for some of the attention that we give them. So we need to have better technology. We certainly need to have perhaps a different configuration to
so
our
you're talking
team
about
and more nurses.
facilitators of that process, but describe the practice that you imagine or see for practice nurses that is a stretch from where they are at the moment, but still within the scope of practice of a nurse.
I actually believe that we will get to a point, as they've done in some of the more high-functioning healthcare homes that I've seen overseas, where rather than having patients necessarily having to come and see a doctor for an extended visit when they need to have scripts refilled, that we'll in fact be able to have the nurses do an awful lot of that workup, because they'll be able to work within protocols, with long-established relationships that they have with those patients, and actually manage even the way we do prescribing differently. It doesn't mean the doctor won't be involved. It can be done safely. It can be done in conjunction with the patient as well. One of the things that happens at the moment is we do have a lot of GPs who do practice 6-minute medicine, so it's all about extract a bit of information and quickly give information and get that patient out the door. I'd actually like to see patients and their families and their care team involved in shared decision making, which at the moment is something that our nurses are adept at doing, have perhaps been trained at doing more so than some other clinicians, and I'd like to see that become a much more endemic practice so that we're all involved in care.
So Bastian, I mean, it's a team-based, I mean, complex care is a team-based sport.
Yes.
Absolutely.
Nurses see themselves, unlike physician assistants, nurses see themselves as independent practitioners, healthcare practitioners. But a common complaint that you hear from practice nurses is that they don't get that independence from the GP. The GP calls the shots, they have to do what they have to do, and they don't get much space to actually do what they're able to do. And they could do a lot of what GPs do to free you up to be more of a consultant and a diagnostician than just taking blood pressures and checking. And I understand, I appreciate when you're in a semi-rural practice you don't do that so much, but that's what metropolitan GPs do. So the question is general practice practitioners, are they up for the independent practitioner within the team who is working to the full scope of their practice, which will mean it will encroach on some things that GPs do, because some of the things that GPs do is actually nursing.
So the answer is, of course, yes. I think GPs are...
I was a cheap shot on my part.
I think GPs... I know. I think GPs are good, general practice nurses are good, but together we're actually great. So I think it's really important not to go down this folly and say general practice nurse can do prescriptions. That's not really what you want to be doing. I don't want to delegate a prescription,
But you've gone through, a lot of training,
Of course.
and you are able to make independent clinical decisions and to be trusted to do so within a clinical governance arrangement. And that's the frustration I hear from lots of practice nurses, that they're not given the trust to make those clinical decisions within a clinical governance framework.
And that's unfortunate, and that should not be the norm. The norm should be that you bring the quality and the professional background of the practice nurse together with the quality and professional background of the medical practitioner to make better decisions to improve health outcomes. And highly functioning general practices are doing this right now. So with my nursing team, that's how it is. I'm not delegating tasks, we're working together. We are sitting in the same room together with the patient, talk about the patient's health. Now, ask me whether it's cost effective or not, probably not, but I know we're achieving better outcomes, and professionally that's actually far more rewarding.
So Janet, tell me how clinical governance is going to work, because if you've got this team that's imagined by, clearly the whole panel believes that that's, and I think you do too, that's what the healthcare home is about, independent practitioners, coordinated, working together, but there's got to be clinical governance for safety, not just for the nurses, but for the GPs as well. How's that going to work?
So we've been quite deliberate that we're not telling practices how to do their business, and that the business, the models of care will come through this first phase. Through the education and training that we're developing, there'll be a whole range of supports around team-based care, the sorts of clinical governance that you would put into play in your practice if you don't already have it. So that comes through, while we're not saying you have to do X, Y and Z with this team member and this is the construct, the elements of clinical governance and what should be considered will all come through that education and training.
So the two top questions here I've got in front of me relate to funding, Janet, and I think it has to be you who answers them. So the practice nurse incentive payment hasn't changed in 5 years, the wages have increased. How do you see funding for practice nursing services changing in the future to achieve a more sustainable and efficient primary health service? Big issue. What's
Yes.
the Commonwealth's position, if it does have one at the moment?
So we have the Practice Nurse Incentive Program, which you would be familiar with, I think.
And that's what they're saying, the money hasn't changed for 5 years.
Yes, so it's currently under review now, and there's a number of streams that are happening in the department that will align and support the work of the healthcare homes. The review of the PNIP is one of those. That's under active consideration now, and we're working closely with that area to make sure that the outcomes of that support the intent of the healthcare homes, but I'm not in a position to sort of say what will be the result of that review yet.
Okay. So, do you have a comment on this, Karen?
I have a comment on clinical governance, and that is that nurses already have a number of tasks that are handed over by the GP as part of that sort of clinical governance outsourcing to a trusted health professional. A lot of the nurses will do the upfront population health screening, identify the patients who are at risk, bring them in, do their assessments, map their care with care planning, and then that patient will come to the GP. So sometimes it's initiated by the GP into that pathway, but in a lot of practices that job is handed over to the nurse to manage that and manage that up to the GP. So that's a clinical governance issue. Currently, just around prescribing, there are only nurse practitioners are authorised to prescribe. That may change. There are a lot of disciplines that are investigating the ability to prescribe, so pharmacists and some nurses as well. Nursing groups are looking at that. There are already nurses that prescribe, so there are the ripened nurses, and there are already nurses that dispense to protocol. So are there any rural, remote nurses here who are in community settings dispensing to protocol? That's right, and if you need the GP on the end of the phone. So there's already that happening. When that does change, and for any handover of items in relation to clinical governance, as long as you've got good protocols and policies set up in your practice, that you know that that person you are handing that activity to is accountable against that policy, then I think there may be a relaxing of the fear of handing over some of those other tasks.
There's a couple of questions here which made me wonder whether there's a bit of confusion between my aged care and the healthcare home. So how do we grow a workforce to meet our community's desire to stay at home? What safeguards will exist to protect the aged from spending their funds on cleverly marketed services they may not need? I mean, that's not healthcare home, is it? That's my aged care. Because we're not talking about the PHN's outsourced services here. This is integrated care within a general practice environment. So there's probably just a little bit of misconception there about what healthcare home is. So, I mean, you're enthusiastic, Leanne. Do you have evidence that it's worked elsewhere? I mean, you ran the National Organisation of General Practice. It's not been the first time this has been discussed. It probably was a AGPN policy long ago, so along with capitation. So, what's the evidence?
Well, look, I think, you know, there's been forays into this sort of model of care, and it's not like, as Tracy said, it's not like we've plucked it out of nowhere. There's a 15-year history that's been tracked and evaluated in the US. Professor Benjamin Crabtree, if you haven't read any of his stuff, he's a medical anthropologist. I was at a seminar with him a couple of weeks ago, actually, and you know, he talks about the sort of impacts that the patient-centred healthcare home transformation journey is having in the US. And the critical point too, I think, is that, you know, it's not necessarily one fixed model. I think we want, and this is probably where the debate about is the funding adequate or not, that's where it comes to its pointy end, because we don't want the funding to be so inflexible that it stifles innovation, because we do want to see models, we do want to see emergent models of innovation, and he talks about hybrid models, he talks about integration models, he talks about add-on models, where you might have an existing high-performing, you know, a NALA style practice where you might just want to add in a social worker, add in a non-prescribing pharmacist. Tick, you know, so it's not like we don't have good, if you use the renovation analogy and extend that to extend that a bit further, it's not like we don't have good bones to build on, Heather, with Australian general practice.
One of the things that we're moving towards, you know, one of the tools for moving towards patient-centred care is to actually know what the patient wants and expects. So patient-reported experience, patient-reported outcomes, the whole ICHOM thing, which has really not yet entered general practice strongly. It's more in the hospital sector. There's some trials going on in New South Wales looking at PROMs in a growing number of general practices, high-performing general practices, using iPads and so on. What role has what the Digital Health Agency is doing in actually helping to record that, so that not just when you bring up the My Health record, you've got the uploaded record, you've actually got what this patient actually wants. Advanced care directives, I expect to be able to go to my child's wedding, I want to be able to, you know, walk faster than I am, whatever the story might be.
Yeah, so patients have an opportunity to put into the record, which is seen by the health professionals, allergies and any over-the-counter medications they're taking. Currently they don't write in there what they want to do, but they do keep that themselves. But the My Health record system is for the patients to look at and understand what is happening in their health care. And I think it's one of the first opportunities that they'll have to see. They'll be able to look at their pathology results, they'll be able to look at their shared health summary, so they'll see what medications they're taking. And so clearly there's a big role to improve health literacy for patients, because that's a big issue.
Sure, but the primary utilisation in the healthcare home, particularly if you want to talk about the frail elderly, is so that the healthcare team knows what's going on. And, they don't have to share. the patient. So the patient will know who the treating team are and what they're adding to the record each time, because they'll be putting something in the shared health summary, they'll be uploading an event summary, so they'll be seeing what they're supposed to be doing, like their care planning process. You might print it out and give it to them, well, they lose it and don't bother with it. But, you know, if they've got it on their iPhones, or their kids have got it on their phones, to support them to do it, because these people all have chronic diseases. They'll be quite unwell, I suspect. They won't be the worried well in the home. So they'll... So there's another top voting question here, which is this question I've already asked, but I think it's top voting because I think we're still confused. And so I'm going to ask it again. I'm not getting a clear description from you about what the increase, if you're working to the full scope of your practice in a healthcare home as a nurse, what does it look like? What are you doing now that you weren't doing before? what training might you need, what top-up, what's the supportive mechanism here to actually allow you? Because you might not have worked to the scope of your practice ever. Well, I mean, GPs haven't worked to the scope of a lot of GPs haven't worked to the scope of their practice for a long, long time, in which case you might need a top-up in training. So what does it look like? Physically, just give us some tangible stuff.
I can do that if you like. So, for example, at the moment, we've got a number of nurse-led clinics that have been funded by the department that APNA is supervising. One of the issues that we've seen over the last decade is a lot of nurse-led models have come to the light, and I'll use wounds as an example. We have a lot of patients, and we will have more patients with chronic wounds. At the moment, to largely pay for that, if it's not a nurse practitioner model, the patient quickly sees the GP, so there's a way of funding for the consumables and the nurse time. There's great models out there with nurses running wound clinics. There's great models out there where nurses can run a whole bunch of refugee health screening and assessment and support. There's great models out there where you might decide that you want to get some extra skills around chronic heart failure, which is a massive cost to our health system. So you actually get involved in a whole lot of the case management, education, support, ongoing triage and monitoring for these patients. And then if they hit certain escalation points, well, then they need to come in and the GP might need to review them in one way or another and make some different decisions about medications or management. So there's all sorts of reasons why, as a nurse, you might be able to specialise in something, just as nurses in hospitals have specialised for a long time. You may choose to remain a generalist because a lot of our patients are also multi-morbid. So nurses that understand a number of disease states and perhaps might be more geriatrician focused or geriatric focused or paediatric focused will have their time to really have a role and a patient group who are known to them, and they're their patients because they're part of a team that supports that patient group.
So Bastian, what skills do you, and infrastructure, so let's put aside more money, because you're saying, well, $4 billion back into general practice. But let's put that to one side of the moment, because you've got to decide what you're actually going to spend the money on. Is it just going to be topping up the salaries of GPs, or is it actually going to be into infrastructure? What, to make your practice, so I'm assuming that you're a high-performing general practice in Tasmania, semi-rural setting. Tell me what infrastructure you need to really fulfill the functions of a healthcare home that you don't have now. To be better integrated, better coordinated, what skill uplift, because this is about people as much as gizmos.
I think that's a great question, because we are the stock standard Australian general practice. So we are in a regional area south of Hobart. We have 14 GPs. None of us work full time, so they all have the same day off. We have 7 practice nurses. None of them work full time. They all have the same day off. There's a nurse practitioner there. There's a pharmacist there. There's good admin staff. But 83% of our patients have either a concession card, are elderly, or are children. So it's a very low social demographic area. What we need to perform really well for our community is we need to be allowed to have more time with our patients. And we currently don't, because the financial pressures are that we have to see 4 patients every hour.
But isn't that what bundle payments allow you to do in capitation?
That's what you think, but again, the patients don't go away, because I would then say, okay, I probably see 20% less of the patients I see before. But because I'm in a community, I can't just say, well, I'll see you tomorrow or the day after or next week.
Let's just look at the evidence base from international general practice. So John Fry, well-known British general practitioner who sort of pioneered how you implement capitation, argued that if you're actually doing your job well, the numbers of patients that you will see in any one day will diminish rapidly.
Absolutely.
And he said, a successful day for me is not seeing any patients at all. And he had one of the lowest rates, and there was no evidence of diminution of health, but he had a team-based care, and we're talking about 35, 40 years ago. So capitation can allow you time.
That's right.
If you manage it well.
But again, that would mean capitation for potential patients, but not a capitation just blindly, for a whole practice system. There's got to be an incentive there that allows your practice to be an incubator. If I want to, do something completely different that may or may not need the need of my community. In our practice, we just tried a model where we just extended the hours. So we were open until 8 o'clock in the evening. We're doing, Saturday until 6 o'clock. because we were hoping that we are preventing hospital admissions and A&E presentations. Turns out it wasn't cost effective because we are trying to get patients in between 8 and 6 o'clock in normal daytime. So again, it was a worthwhile experiment to actually do. So again, we needed some extra funding to see whether it makes a difference to our community there. Look, the problem really is we don't need to reinvent the wheel. That's really difficult. General practice has been shaken and stirred a fair bit over the last years. And my feeling is we are barking up the wrong tree. General practice with GPs and practice nurses is not the main cost driver of the Australian healthcare system. It's hospitals, it's medication, it's pathology and diagnostic imaging. So we've got to be careful not to put the wrong incentive into general practice by coming up with new funding models that really haven't shown to make a major difference internationally.
Janet, what's your comment to that?
I think we're talking about wanting the same things. We want the GP to have more flexibility, the team to work better together, and to create a mechanism to allow better time for people with chronic and complex disease. The bundle payment also has a fee-for-service element running alongside it. So for those issues that don't relate to a chronic disease,
so in the same patient?
In the same patient. So we expect that to be relatively small if we've got the bundle right to cover the chronic disease. But if you have something that's not related to your chronic disease, you still get to bill fee for service. So in effect, it's a blended payment system where we're running two systems together. So we do see that this is actually, we're trying to achieve the same thing, and I think we're changing the mechanism to support that environment and to create exactly what we've been talking about.
So a couple of questions. Sorry.
Norman, can I add to that?
Of course.
I think it goes back to when you do become pot-bound with the number of patients that you can possibly physically see in a day as a GP, you then need to look at, well, do I really need to see that patient? Yes, that patient needs to see a health professional, but there are other health professionals that can see those patients, particularly for smaller things, and manage them. We have shared medical records. The GP can see when that patient came in, the type of care they've had. The same as I can see when the patient's seen a GP. We share the record and that continuity of care is there, but they don't necessarily need to see the GP at the same time. And just on back a couple of points where we talked about what practices need for infrastructure, I think investment in upskilling team members is important, and often particularly upskilling nurses and the cost of sending them to courses is seen as a cost. If we buy software and we update our medical director and update our best practice, we see that as an investment in running the practice. If we send our nurses to education events like this or other courses, that's actually an investment for what they will bring back and help to put some meat on the bones of that infrastructure of your practice.
So I know AGPAL is setting up some standards around training. Mm-hmm. It's hard enough to get continuing training, CPD, going in hospitals, getting people time off, space to train, and blah, 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 blah. And general practice, particularly training general practices, who are taking registrars and so on, do have some spaces there, and they've had some money to actually develop that. But, I mean, is it realistic to think that you can actually free up a busy practice nurse for training, desperate though the need may be? Karen?
I think it goes back to that view, is this a cost or is this an investment? And you make an investment.
But you've still got to continue the business of the practice, which is what hospitals say. We've got all these people coming in through the door. How can we let them off for a training day?
If you want to further what you're doing in a practice, and if you want to actually implement a program, you have to actually teach someone how to implement that program, or you need to look at what are the skills that we need to actually implement and take us in the direction that we want. So it is an investment, and maybe you need to timetable that time off. Maybe you need to get in a locum, but you need to think of that. That all of that activity is actually building that infrastructure to lead you where you want to go.
And actually, my understanding is that the evidence about retention of nurses in clinical care is about career development and training rather than money.
That's correct.
So I think this is for both Leanne and Tracy. There's a couple of questions here about homeless and transient populations and how really the healthcare home can help them, because these are, it's a wicked problem, and it's going to be hard for the healthcare home to deal with it, but can it?
Yeah. So one of the things that excites me most about where healthcare is going is so much of what we do at the moment is reactive, and we actually medicalise what are social issues. So for me, I'm quite excited about the conversations we can have in this country about how do we get a continuum of health and social care working together. So in a healthcare home environment, I see the opportunity for us to actually have more touch for patients and more different types of touches, so different modes of delivery and different places of delivery. So for people who are transient, we work in a really disadvantaged population. We do have people who live out of their cars and who are suddenly thrown out of rental accommodation and all sorts of stuff. That's pretty normal for the work that we do. So in terms of how do we bundle activity around those people, I think we need, just as our Indigenous health services for a long time have had link workers and Indigenous health workers and those sorts of resources that they can draw on to demedicalise or to intervene earlier before things hit a crisis point that is quite medical.
But given that, I mean, I understand that enrolment is optional. That's right, Jen?
No.
No, enrolment is not optional.
No, it's not. You have to enrol.
So enrolment is going to be a problem for such populations if they're transient, they're homeless, they're here today, gone tomorrow. I mean, I'll come to the issue of enrolment with Leanne in a moment. I mean, it's going to be hard for you to deliver that service under the healthcare home if enrolment is part of the deal.
Not
Tracy.
necessarily. For some of these people to actually feel that they're part of something and that somebody values them and is making a special effort, and in communities like ours where there's enough of these people, you can then have, you know, the ability to resource a particular type of program and model of care for these people. They do have mobile telephones, they do have networks that you can access, and the reality is this care is hard care now. So, you know, it's going to remain hard care, but at least we'll have more choices and flexibility about how we go about it.
So Leanne, one of the problems in general practice at the moment is loyalty. You know, people don't have the loyalty that they used to have. And they, you know, GPs are often surprised. They've spent years caring for this family, and then they discover they've been going to the bulk billing clinic down the road, who've actually stolen the enhanced patient care items, and but you come back for the chronic care. Still happening, obviously, from the reaction of the audience. How realistic is it to expect that consumers is the value proposition strong enough that patients will register?
Look, I think the value proposition is strong enough because, the concept of a single healthcare destination that does what Tracy's talking about, particularly for complex people, that offers wraparound care, that has the autonomy and the flexibility in terms of the workforce and the way they configure their teams and their clinicians, the way they ideally integrate in and connect with social care services in the community as well. That's where the opportunity lies. We're seeing some of that practice already. I think what's being underestimated here, and we shouldn't underestimate it, and it does need to be invested in, is the extent of, the first point is the extent of change management and organisational development that really does, and service redesign that needs to occur at the general practice level in order for the curve to be flattened out. We're always going to have our champions and our leaders. We're going to, even within the healthcare home cohort, we're going to have our champions and leaders and the ones that are going to really struggle with this. So change management and investing in the practice redesign, practice innovation, new models of care it's got to be funded appropriately. And the other thing is cultural change. We need the mindset in the model that this is more than medicine, that we do have an opportunity here to configure teams, and it's not hard. I mean, I know of a practice down in Bega that all under current arrangements, current models, employ a social worker. Yeah. To bring in some of that social prescribing. It's doable. So the other point I would make, Norman, just to answer your question too, though, is on enrolment and on what is the point of difference now, between now and what we might end up with under the healthcare home pilot. We do need some public education. We do need some patient education and communication about what that point of difference is, what is that value proposition. I don't think we can just say we're going to flick a switch on the funding model and they shall come. You know, I do think, you know, the value proposition needs to be reinforced and communicated.
Another question, so I'll just very briefly, Bastian, what do you think the value proposition is to get people to enrol? Even though you're sceptical about the healthcare home, but let's assume that it's going to go ahead, what do you think, if you were the healthcare home, what's the value proposition that you would have to offer your patients to make it worth their while enrolling? Because most general practitioners would actually quite like the idea of enrolment so that you've actually got a practice population that you know and you can look after.
And enrollment doesn't happen now, but de facto 80% of all Australians can still nominate their GP or their practice. But healthcare homes as a model now doesn't address the fragmentation that patients also go to the bulk billing practice down the road. And that's probably something we should have addressed. How do we ensure continuity of care, that the patient generally is able to go to see their doctor?
So just hold that, what happens with that? I mean, it's a good point, Janet.
So the patients, when we bring the patients into the healthcare home, there'll be a range of consents that they sign on to. One is that they nominate a home base which they need to direct all or engage all of their care. We are working with DHS to be able to track patients' expenditure. If they do go outside that practice, then we can let the practice know and they can have conversations with them. So there are ways that we can assess whether the patient will be using services outside of their healthcare home, and there may be valid reasons for that, but it allows that conversation to happen between the team and the patient to reinforce the intent of what we're trying to achieve.
A response from the audience there?
Would any... Hang on, I'll come over. It's okay. It must have been a big ooh.
You can't cackle and not take responsibility for it.
I was just a bit surprised then that it's going back to the GP, that the GP has to facilitate the patients, you know, telling them that they can't go to another doctor. I just thought that was interesting.
The team that's within the team that's looking after the patient can have the responsibility for the engagement with the patient, but we would be tracking the MBS expenditure, so it would be us detecting that they're seeing another doctor. That's what I meant by saying that. That's how we'll be able to see that they've gone to another practice.
And then the GP has to tell the patient that they're not allowed to go to another doctor for the chronic disease management.
So we're not taking choice away, but if you are going to participate in the healthcare home trial, a part of that is acknowledging that you will have a home base. That's where you're going to enrol, and that's where the majority of your care should take place.
But I'm assuming then that what you're saying is that you'll detect that and it's an opportunity to learn, because obviously there's a failure in the system if they're going down the road for some of their care and not going to their home.
Yes. So you'd be talking to them to understand why they've gone to a different practice. Was they just didn't understand the healthcare home model, or there was a reason they're not happy with the care that they're getting? There could be a whole range of reasons, and we can unpack that.
We just have another comment over here.
I'm just wondering how that'll impact on those patients that make a choice to see different doctors for different purposes, like those whose own GP doesn't do skin as a specialty, so they go to another doctor, or a patient who has a GP that they love and adore, but will go to a female GP to have her gynecological stuff done. Yeah. Is it going to discriminate against those particular people?
So we recognise with chronic disease management, you may well need to see multiple providers. Where it's care that should be provided by the team in the primary care setting, then that is provided through your home base. But your care plan should be able to determine exactly who you need to see. It's all supported through the healthcare home, and it's a more coordinated and joined up approach. So the communication is happening between the providers, but it doesn't mean that because you can't get that care that you need, you can't then go and get it where it's required. It's just done in a much more coordinated fashion.
Just a question here for you, Heather. Is My Health Record dynamic enough and immediate enough to be able to get the information? So I've seen somebody and the information is up to date enough that I can actually make clinical decisions based on My Health Record and this sort of system.
Yeah, at the moment, if you get a shared health summary uploaded in the afternoon and end up in an emergency department that evening, they'll be able to see it. It's instant. It's
Right, so
it's immediate.
But it depends on the uploading.
Yeah, like your discharges coming from hospitals, they may not send a discharge for a couple of days, but those hospitals that are sending them immediately will certainly, you'll get it the next, straight away.
Comment over here?
Yeah, we've just got a question here about confidentiality.
Sorry, I come across a lot of patients that have concerns about confidentiality, particularly maybe their employers finding out about what doctors they're seeing and all these sorts of things, so they're really strict about that. So I find that maybe some patients would be reluctant to enrol because they'll get the sense that they're being monitored or tracked as to where they go and what doctors they're seeing. So if a patient refuses to enrol, does that mean that they won't get seen? Or what happens? How is that GP going to then take care of that patient?
So it will be a requirement for the patient to enrol with the healthcare home. If that's not their preference, then they stay within the existing Medicare system, which provides the care that they'd be getting now. But the confidentiality around the data will be protected as it is now. The My Health Record data has all of the privacy provisions to support the confidential nature of that information. The information within the practice is only for the people, the team that's involved with that care. It's not shared with employers or goes outside the team. It's held confidential like it is now.
And so, another question here, we're going to have to wrap up in a second. How will the healthcare home work with NDIS? Have you thought about that at a policy level, or is that up to the individual healthcare home?
So we have been having discussions with DHS around the NDIS and how the healthcare home and the NDIS may interface. So if we had somebody with an intellectual or a disability who's come in with chronic disease, we are looking at how the coordinators would come together and have the shared care. All patients will be required to have a shared care plan that all of the team members will contribute to, and we see that identifying what the patient's goals are and then helping to inform what other social supports they might have access to. So NDIS, aged care, mental health are areas where we see significant overlap with the chronic disease patients, and we would use the shared care plan as a way to be able to try and integrate some of those supports that they may be able to access across the system.
We've run out of time. Could you please thank our fantastic panel? So within the next few days, we'll hear, and I'm sure there'll be some people, hopefully many people in this room, who will be participating in the healthcare home trial. It's too important not to work, and hopefully we will all be engaged with that and work with consumers, our patients, closely to make it as much of a success as we can. Thank you all very much indeed, and I'll hand back to you.
And thank you, Norman.
Thank you, Norman.
Thank you so much.